And the recording is on.
Okay, so good morning, everybody. I'm Joe Carver, and with me I have one of the Abramson Cancer Center Hematology Oncology Fellows who's going to join me in the presentation. And I'm going to give the microphone to Yehoda to begin with the case. Here we go. Okay.
All right. Hi, my name is Yehoda Martei. So this is a case of a 76-year-old woman who was admitted to the hospital of the University of Pennsylvania with fevers and pancytopenia. So she had initially presented to an outside provider 3 months prior to her admission, and this was in September 2014. She had presented with fatigue, anorexia, and weight loss. The workup at that time showed that she was anemic and presumably B12 deficient as well, and so she was treated with B12 injections weekly, but her anemia got worse, and she developed new neutropenia as well. A couple of weeks prior to her admission, she developed night sweats. She had easy bruising, and by the time of her admission, she had lost 24 pounds over the last 3 months. A bone marrow biopsy was then performed at an outside hospital. We didn't have the results of this when she was admitted, but it was concerned for AML, and so she was subsequently transferred to HUB. So her past medical history was notable for diabetes and hyperlipidemia. She was social history was notable for the fact that she was born in India, but currently resides in Abu Dhabi in Philadelphia with her husband. She travels back and forth to India frequently. She has 2 adult children and 5 siblings. She had no bad habits, so didn't smoke, denied alcohol consumption, and no illicit drug use. She previously worked at the Children's Hospital of Philadelphia in the radiology file room. By the time of admission, she had retired. Her family history was notable for no known history of malignancy. She had allergies to penicillin. It was just a rash. And in terms of her medications on admission, so she was taking metformin 1,000 milligrams BID for her diabetes. She had been started on Megace 3 months prior to her admission, and this was for the anorexia. She was also on pravastatin and taking a multivitamin daily. So on admission, her initial CBC, complete blood count, was notable for a white count of 1.9. Her ANC was 800. Her hemoglobin was 8.6, and her platelet count was 235. A bone marrow biopsy, a repeat bone marrow biopsy, was performed at our hospital, and it was consistent with AML. She had 23% blast on aspirate, and the flow cytometry was consistent with AML blast. Her cytogenetics were normal. Her leukemia translocation panel was negative. NPM1 and FLT3 testing was also negative, and she had CPD testing. So this is a series of mutations that are tested at the University of Pennsylvania for research purposes, and not all the mutations are actionable. So that showed DNMT3A mutation, WT1, and ASXLR1 mutations. So this time we had established that she had a diagnosis consistent with AML. So we did some basic workup prior to initiating therapy.
So you can see her electrocardiogram shows sinus rhythm, not very remarkable. Would point out that the voltage is normal, and that's maybe important as we go forward.
So she, so we discussed induction chemotherapy with her, and we talked about standard induction chemotherapy with 7 and 3 versus enrolling in a clinical trial, the ECOG 2906. So the ECOG 2906 is a clinical trial in newly diagnosed AML patients who are older patients defined as greater than or equal to 60 years of age. And this is a phase 3 randomized trial looking at induction therapy with clofarabine as induction and post-remission therapy. versus standard therapy with daunorubicin and cytarabine, followed by intermediate dose cytarabine, post-remission therapy. And then further on, patients were randomized to either decitabine maintenance versus observation. So we had a long discussion with the family and her children, and she agreed to enroll in the clinical trial. She was randomized to the clofaravine arm and received 30 milligrams per meter squared per day from day 1 to 5. So on her day 1 was November 14th. So just to highlight again, so she actually came in with fevers and pancytopenia. So her fevers actually persisted throughout her admission. So on day 6, she was finally neutropenic, and so we defined this as a neutropenic fever and performed workup as usual for a neutropenic fever. So her blood and urine cultures were negative, which is not unusual since more than 50% of our patients with neutropenic fever would have negative workup. She was treated empirically with antibiotics, and so was started on meropenem, and then escalated to vancomycin, and then eventually voriconazole for empiric coverage of neutropenic fever. She continued to have fevers, and so we did further workup with imaging studies, and so we had ordered a CT of the chest, abdomen, pelvis, and then also of the sinuses. So her CT of the chest and abdomen showed some lymphadenopathy, but no pathologies. The pelvis and the sinus were negative, and so we continued antibiotics. So on day 13, she's still having fevers despite being on broad-spectrum antibiotics, and the question that came up was whether her fevers were related to her AML. So she was still spiking very high fevers, up to, I think, 104. She had very high-grade fevers. And so at this point, we were concerned about whether her fevers were actually related to AML. And so we did her day 13, well, day 14 marrow to see if she had any residual disease that could be, that we could attribute her fevers to. So her day 13 marrow actually showed a chemoablated marrow with a minor expansion. So she had 5% of immature monocytes. Her correlative WBC at that time was 0.2, hemoglobin of 9.6, and her platelet count was low. So she continued, so by day 20, her neutrophil count was starting to recover. At this time, she still had persistent high fevers and sinus tachycardia as well.
Yeah, and here's her cardiogram at that time. Does anybody want to comment? Okay, so just sinus tachycardia, that there is a little hint of PR elevation in V1 and a hint of PR depression in lead 2, but I think it's pretty subtle, and without maybe a retrospectoscope, it may not be that obvious. So
hello,
we'll
Joe.
throw it out. Yeah.
Yeah, I was going to ask you, we've got a protocol that on ladies over the age of 50 and men over the age of 40 that are going to get potentially cardiotoxic chemotherapy, that we do a coronary CT and look at the coronaries as a baseline. And I saw that they had a CT scan on her. Even with the tachycardia, you can get a decent gait, because the story is that the heart rate has to be regular, and the regularity of the heart rate is the key, not the heart rate itself. And so we've actually taken patients and paced them at a rate of 107 and gotten beautiful studies. So is there any consideration of adding that to a protocol, especially a patient who's diabetic and basically has some risk factors for heart disease, probably increased cholesterol?
Yes, so we don't routinely do that. It's an interesting suggestion, but we don't routinely do it. And so let me throw it back to you and ask what the yield is, and from an actionable standpoint, what do you do differently with the results?
Thank you. We probably will have something perhaps in time for October meeting for a poster or something. And so we are basically putting that together and that information together. We are interested in if you have no coronary disease, because that gives us the reassurance. And then we're interested if you have some calcific nodular plaques but no non-calcified plaques, because again, you have a low rate of potential events. For patients who in the future get radiation to their heart, we've got a baseline, which is very useful. And then patients who have mixed plaque that has some potential as vulnerable plaque, and we're interested in containing that in some fashion in terms of medical management. And then patients with severe stenosis. That's very interesting to know, because those patients are at high risk.
Yeah, so the problem is we manage, I'd say, not that I'm a nihilist, but I think that we manage all people that are young over the age of 60 as potentially high risk, that we take care of risk factors. We clearly would not like to fix lesions prior to making people totally pancytopenic. So, I mean, it's an interesting issue about does it really alter what you do? We still stay aggressive and try to maintain statin therapy. There's even some interesting data that statins may reduce GVH. So I'm not sure, other than if they got chest pain, you may have a lower index of suspicion to be, to listen to the patient, that it changes very much what we would do, because and I'm not being negative. I'm just saying that I hope that you in your poster can say we've really made a difference in how we care for people because of this.
That certainly will make a difference in my life. If I get a call at 2 o'clock in the morning for chest pain, it makes a difference in my life.
Okay.
Joe, it's Alex Lyon here from London.
Yeah, go ahead.
So obviously biased by the fact that we're all cardiologists and you're presenting a cardio-oncology case, but the thing that obviously goes through my mind now with unexpected or unexplained fevers is endocarditis. And then maybe the interesting thing is that she was treated for you said for a few weeks by the original centre with vitamin B12 injections. So you've got a potential sort of source in the context of someone with developing immunosuppression for repeated sort of breaches of the skin and potential for a introduction of bacteria. So I wonder, first of all, clinically, whether she had any signs that you, in retrospect, could put down for endocarditis. And then, of course, with that potential change in the PR, I was wondering, actually, you mentioned sort of change in the isoelectric line, but actually I was wondering whether she had disproportionate PR prolongation for the tachycardia on that ECG, and whether, therefore, thoughts about an aortic root abscess. But this is all in the context of us as cardiologists looking at this case. And picking up on what Eric just said, she's an elderly lady. One of the drugs that was being considered was daunorubicin, and whether she would get a baseline echocardiogram before potentially going into that treatment cycle based on age and diabetes as risks for potential cardiotoxicity. I appreciate she then ultimately went into the trial, but whether a baseline echo may have actually picked up something on a valve or a root, if this is what it transpires to be.
So with regards to suspicion for endocarditis, she didn't have any skin findings or any lesions that would be consistent with endocarditis. She didn't meet any criteria, any of the Duke's criteria as well. And with regards to getting a baseline echo, so she actually needed to get an echo and have an EF that was greater than needed to have a normal baseline echo in order to actually qualify for the study. I don't actually remember what her exact EF was, but presumably her EF was normal and her baseline echo was normal, which made her eligible for the study.
Okay, so we'll keep going.
So in terms of further workup for her, so at this point, this was day 20, her neutrophils had recovered, and so we repeated the CAT scans again, and this was in the hope that whatever underlying condition she had for her fevers would be unmasked. So we got a CT of the chest, actually looking for a pulmonary process, but instead that showed a large pericardial effusion. We also got a CT of the abdomen pelvis, and when you look at the spleen on the right side of your screen, there's sort of multiple hypoattenuating lesions that was read by the radiologist as being concerning for disseminated fungal infection, probably candidiasis. So based on the concern for disseminated fungal infection, we had ophthalmology see her to assess her for ophthalmologic eye involvement. And based on the exam, it showed multiple bilateral chorioretinal lesions, suspicious for fungal infection, without associated vitritis, and no visual complaints at the time of the exam. So at this point, just to summarize her clinical status, she was no longer neutropenic, as I said, but she was still spiking really high daily fevers, up to 104. Her fevers were actually symptomatic, where she'd get delirious and tachycardic, but we had her on around-the-clock Tylenol, and she was still spiking through this. She had no chest pain with regards to the effusion we saw, and she had no shortness of breath as well. Her exam was still non-focal, either neurologically or cardiologically as well.
Yeah, so at this point, because of the effusion, they asked us to see her. So this was our first involvement, and the question was, what should we do about the effusion? And you can see that there is a large effusion. Our ventricle was normal. There were no valvular lesions on the echo. Her exam, there was no evidence of increased intrapericardial pressure. She had nothing that looked like tamponade, and we thought that with the persistent fevers that we ought to get some fluid and make sure that this isn't infection, as the suspicion for endocarditis was there also. But it was that's where we ended up. She had
So she had a pericardiocentesis performed by CT surgery. They drained out 650 cc's of serosanguinous fluid. The WBC in that fluid was 156, predominantly lymphocytic. So there was gram stain and cultures sent on the fluid, which were negative. It was also sent for cytology. Given the malignancy history, that was negative. There was no yeast or fungal elements on the fungal stain.
Yeah, so there are times when you need to get pericardial fluid to help with diagnosis, and tamponade is not the only reason to get fluid. Unfortunately, she didn't have very good. Let me just backtrack and say that the cath guys are psychotic about having anterior clearance by echo, and they won't. They are reluctant without clearance to stick a needle in for any reason. So we could not do this percutaneously. I don't know how it is in every other place. I know at other meetings I've heard our German friends say that they will stick a needle anywhere, anytime, but people here are really conservative. Any comments?
Yeah,
Okay.
I can comment from the UK perspective. On one hand, our cardiologists, interventional cardiologists, would be happy to do this in terms of a percutaneous pericardiocentesis. I think the only question is whether there's ever a value of also getting some pericardium, in which case we also have surgeons, both thoracic and cardiothoracic surgeons, who are very comfortable doing thoracoscopic pericardial windows and biopsies plus drainage. So as part of the workup, we'd probably do a CT or MRI to look at the morphology of the pericardium and then make a decision about whether there's added value of getting some tissue from the pericardium for a diagnosis. Obviously also in metastatic disease for therapy as in terms of the window. But my other comment here, of course, thinking back to her Indian heritage, is tuberculosis. When as soon as you see pericardial changes, and obviously with her immunosuppression. So I just wondered if there was anything on stain and whether it was all sent for the appropriate TB cultures.
Okay, well, let's continue. Here are the hemodynamics before and after. I think that the thing that's always interesting to me is that even large effusions that don't appear by exam or by echo Doppler to be hemodynamically significant are always hemodynamically significant, and they do affect cardiac output, not to a level that causes tamponade, but large effusions in people that are symptomatic. I've over the years have softened my trigger finger about taking out fluid when people have symptoms, because that we don't always make the right diagnosis about tamponade, or at least about the hemodynamic significance of large effusions. Okay, we'll continue.
So at by day 28, we've had negative cultures so far from the pericardial effusion, and so we repeated her marrow to see if perhaps recurrent leukemia could explain, residual leukemia could explain her fevers. Her marrow actually showed normal cellular marrow with tri-lineage hematopoiesis, and essentially was normal, showed no overt residual or recurrent leukemia. And she was still having fevers at this point. So based on the fact that her marrow wasn't the cause of her fevers, we didn't think her leukemia was, we went back and sort of got further history, and it turned out that she'd received the BCG vaccination as a child. What we also found out was that her son had a history of active pulmonary TB, which was treated, but the patient was not previously treated for latent TB infection. So a differential diagnosis at this point was mainly either disseminated candidiasis, like we talked about, versus disseminated TB causing the pericardial effusion. This was a summary of additional workup we got. It was more extensive, but the relevant ones were that we actually sent quantiferin, which I'll talk about later, but it was indeterminate. We sent thick and thin smears looking for malaria or other parasites. That was also negative. So based on her intermittent delirium with her fevers, we also did a lumbar puncture. Her CSF analysis were all negative. Histoplasma was negative. And of note, all fungal markers were negative. So her beta-D glucan was negative. And we tested for HIV, which is negative. So at this point, we had more data going for fungal cause than for TB, or at least we had sort of imaging studies that were more in support of a disseminated fungal infection. And so we started her on Abramson, and the choice of Abramson was because it had better eye penetration for presumed disseminated candidiasis, and she actually had clinical improvement for a couple of days after starting Abramson. But then on day 41 of her admission, so this is now 6 weeks into her admission when she'd been spiking multiple fevers, the AFB stain resulted positive from her pericardial fluid. On day 49, So the AFB stain, when positive, is not specific for Mycobacterium TB and was stained positive for a lot of other Mycobacterium. So we had to wait for the cultures to come back. So on day 49, her cultures came back. She had 10 to 50 colonies of Mycobacterium tuberculosis complex. A diagnosis at this time, based on our culture result from the pleural fusion, was that she had disseminated TB with pericarditis, possible chorea retinitis, and then also possible splenic involvement. So I'm just going to talk briefly about Mycobacterium TB and then talk about some of the studies in terms of TB management and management of TB pericarditis. So still very common, there are 9 million cases worldwide. In the US though, there are 9,500 cases of active TB that were reported in the US in 2013. In the United States, the greatest incidence is actually among foreign-born persons. So 2/3 of the active TB cases reported are all foreign-born persons. Also people with low socioeconomic status, immunosuppressed patients, which the common populations actually are defined as patients with HIV and diabetes, and then also patients who are older than 65 tend to have a higher rate of progression from latent TB to active TB. Specifically for hematologic malignancies, there is an increased risk of TB reactivation in patients undergoing bone marrow transplant, and this is because of prolonged immune suppression associated with BMT. It's much higher for patients who have chronic GVHD and have to be on immunosuppression for a prolonged period of time. So the questions that we had asked was whether there was a higher incidence of TB reactivation either with clofarabine or 7+3 induction. So there isn't much data on this, but there are few case reports actually with both. And so there have been cases of active TB with both clofarabine and then patients who also got 7+3 induction. So we didn't think it was specific to that. And so we reviewed the literature briefly just to see if there were any particular therapies that we gave in patients with hematologic malignancies that could predispose to TB reactivation. So specifically we have 5 cases of TB between 12 and 20 in patients who MPAT. And so in patients who are high risk, there's actually a recommendation by the FDA to do PPD testing or prior screening for latent TB prior to initiating CAMPATH. And then latent TB, so latent TB is patients who don't have active TB. So in the US, there are 11 million cases. So the main way latent TB is diagnosed is either with a tuberculin skin test, which is the much older testing, also known as the PPD skin test. So this is basically a delayed cutaneous hypersensitivity response to a mixture of MTB proteins. The disadvantage of the PPD skin test is that it may be falsely negative in patients with active TB. And then secondly, in patients who've received the BCG vaccination, because of cross reactivity, it can also be positive, even in patients without latent TBI. So then the quantiferin or TB-GO test or T-spot testing is the more newer method of testing for latent TB. And what this does is, so it's an ELISA assay that basically measures interferon gamma release stimulation in vitro. And so the patient's blood is mixed in vitro with a complex of 3 different mycobacterium. And there's an ELISA test used to measure how much interferon gamma is released. And so obviously the downside of this is that you have to have a competent immune system to actually elicit a response. And so in our patients with malignant hematologic conditions or with immunosuppression, the test can be falsely negative or indeterminate, which was the case in our patient. But then I also wanted to point out that it hasn't actually been validated in the diagnosis of active TB, and so the test can be positive either in latent TB or in active TB, and so it's not a diagnostic test that has been approved by our FDA for diagnosis of active TB. And so the question is, how do we diagnose active TB and especially extrapulmonary TB? So a lot of the symptoms that patients present with are very non-specific. So there's cough, weight loss, fever, night sweats, hemoptysis. So the cough and hemoptysis are with active pulmonary TB. But the rest of the constitutional symptoms actually have a huge overlap with patients with different hematologic malignancies, and so it's very non-specific. If there's a suspicion for active pulmonary TB, the diagnosis is usually a lot more straightforward because patients are either producing sputum or have lymph nodes that can be biopsied on bronchoscopy. I think it's more challenging in cases like our case where you're suspecting extrapulmonary TB. So if there's a suspicion for extrapulmonary TB, the recommendations is actually to go after the site where you suspect reactivation and then either get fluid or do a biopsy. And so in some cases, the yield of these tests are actually very low in extrapulmonary TB, and I'll talk about the yield for TB pericarditis. But actually, no, I'll just talk about it now. So the yield for TB pericarditis with the pericardial fluid is actually anywhere from a little over 0% to 40%. So we may have gotten lucky that her AFB stain came back positive. The yield is slightly higher when you actually do a pericardial biopsy. In cases where extrapulmonary TB is suspected and there are negative diagnostic tests, there's actually some recommendation by the WHO that you can initiate therapy based on the suspicion. And this is more in patients who live in endemic TB areas. So specifically for TB pericarditis, there are a few hypotheses in terms of the pathogenesis. So it's thought to be retrograde lymphatic spread from peritracheal or peribronchial mediastinal lymph nodes, or by hematogenous spread from primary TB infection. The 4 pathological stages that have been defined for TB pericarditis. So there's an initial stage where there's just fibrinous exudation with initial PMNs, relatively abundant mycobacteria, and early granuloma formation with loose organization of macrophages and T cells. We believe that our patient was in the second stage of TB pericarditis, and so this second stage is mainly a stage where you have predominantly a serosanguinous effusion with predominantly lymphocytic exudate, with our patient had, with monocytes and foam cells. And then the third phase is when you have absorption of the effusion with organization of granulomatous caseation and pericardial thickening caused by fibrin collagenoses, and then ultimately there's fibrosis. And then the last stage, which is sort of the feared complication of TB pericarditis, is that you develop constrictive scarring and then over time develop constrictive pericarditis. It's associated with, there's a high mortality rate associated with TB pericarditis. So at 6 months, the mortality rate is 26%, and it's even higher in patients who have co-infection with HIV/AIDS as well. It can be as high as 40%. Okay.
This is from an African study in a high endemic area, just showing the presence of physical findings that may help in making the diagnosis, but you can see that signs of increased pericardial pressure are generally not present with effusions, and that the elusive pericardial knock is not present at least not appreciated very frequently. And some of those third heart sounds, I suspect, are really pericardial knocks that people didn't recognize.
So then the question, now that we had diagnosed her with TB pericarditis, the question was, how do we treat TB pericarditis? And luckily for us, there's a paper in the New England Journal of Medicine published, I think in September or October last year, which was looking at prednisolone and Mycobacterium indicus prini and TB pericarditis. And so the WHO and the bunch of recommendations that are a bit conflicting in terms of the role of steroids in TB pericarditis. And there have been a lot of smaller studies looking at whether steroids actually decrease constrictive pericarditis and whether it improved mortality. But based on the small studies and also retrospective data, there wasn't conclusive evidence. And so the goal of the study was to see if prednisolone and then the Mycobacterium indicus prini, which is also Mycobacterium W, was to see if immunotherapy also improved survival and pericarditis, in constrictive pericarditis in patients with TB pericarditis. So patients were, so I'll talk about the trial design. There were 1,400 patients. So this was a study that was actually conducted in South Africa. It involved 8 different hospitals, and there are a lot of hospitals, but 8 different countries in sub-Saharan Africa. So there were 1,400 patients accrued, and patients were randomized either to 6 weeks of prednisolone versus placebo, and then further randomized to receive Mycobacterium W versus not. And the composite endpoint was, the complete endpoint was the major endpoint was to assess the composite of mortality, recurrent tamponade, and then constrictive pericarditis. So in terms of the baseline characteristics of the patients who were enrolled, I think just in case of, just to see how extrapolatable that this study is, it's important to note that about 70% of the, so only 16% of patients actually had a diagnosis of definite TB pericarditis. The rest were probable. So 10% had TB proven elsewhere and had indications suggestive of TB pericarditis. But for the remaining 71%, these were patients who didn't have TB proven elsewhere, and the diagnosis of TB pericarditis was presumptive, or based on this diagnostic index. So there's the Tigerberg Diagnostic Index score for TB pericarditis, which has actually been proven in patients in endemic TB areas to have a sensitivity of 86% and specificity of 85%. So the criteria includes weight loss greater than 10%, night sweats, fever, serum globulin, and then also white cell count less than 10. And patients get different scores based on what criteria they meet. And a total score of greater than or equal to 6 was thought to be sensitive and specific enough for TB pericarditis. So a lot of the 72%, so basically the patients in this group met all of this criteria. I think what makes it challenging, especially with our patients with heme malignancies, is that almost all our patients would meet this criteria for TB pericarditis. And so this actually works in areas where TB is endemic. So in terms of the major results of the study, so comparing patients who got prednisolone, who were randomized to the prednisolone, and then to placebo, there was no difference in the composite outcome. So no difference in the combination of death, cardiac tamponade requiring pericardiocentesis, or constrictive pericarditis. However, when they looked at just the outcome of constrictive pericarditis, there was actually a significant benefit in patients who got prednisolone, and so they concluded that getting steroids actually significantly decreased the rate of constrictive pericarditis. Other findings in this study was that in patients who got prednisolone, there was actually an increased risk of time to malignancy. But of note, this increased risk was in patients with HIV, and most of the malignancies were actually HIV-associated malignancies, so Kaposi's, and So I think it's just important. It was important for us to note because it doesn't exactly extrapolate to our patient. So the major conclusions for this study, oh, and I should mention that, so the MW, so the Mycobacterium W arm, so that is basically a saprophytic non-pathogenic mycobacterium, and the thought was that it would stimulate the immune system and create sort of an immunotherapy effect. But then in interim analysis, that arm was actually discontinued for futility. And so the major conclusions from the study was that prednisolone for 6 weeks and then MW for 3 months did not have a significant effect on the combined outcome from death from all causes, cardiac tamponade requiring pericardiocentesis or constrictive pericarditis. And then both therapies were associated with an increased risk of HIV-associated malignancy. So I think the thing that was relevant was that for us was that the use of steroids actually decreases the incidence of pericardial constriction and hospitalization, and it was similar for HIV negative and HIV positive patients. And this, I think, is a significant enough outcome for us. And so in our patient, she was started on RIPE, so rifampin, isoniazid, pyrazinamide, and ethambutol as induction therapy for her TB. We had debated about starting steroids, but she 2 days of starting RIPE, she acutely decompensated, and so we were concerned for sort of iris phenomenon, and so immune reactivation constitution syndrome, and so we started her on a very short course of steroids. She was subsequently discharged from the hospital and was following up with the Philadelphia Public Health Office. But on the 16th of last month, her susceptibility testing came back. It was isoniazid resistant and susceptible to rifampin, pyrazinamide, ethambutol. So she doesn't actually meet criteria for MDR TB, so multi-drug resistant TB. But in terms of changes to her therapy, so instead of three times a week dosing for RIPE, the recommendation is to give daily dosing in patients with isoniazid resistant. So she's getting daily dosing now. She's on her 2nd month of therapy. In terms of duration of therapy, in patients with TB pericarditis, there isn't specific guidelines about the duration. 4 months is generally recommended unless you have meningitis or TB involving the bones. And in patients with isoniazid resistance, the recommendation is to add ethambutol to the maintenance phase of her TB regimen. And like I said, 7 to 10 months is recommended for TB meningitis and osseous involvement. And then I just wanted to add another line about another FDA-approved drug called bedaquiline, which is the first FDA-approved drug for TB in 40 years, which has high efficacy. The uptake has been much lower because of an increased risk of death that was found in the bedaquiline arm. And so in patients who were randomized to RIPE and placebo, there was a rate of death of 2.5% compared to 11.4% in patients who got bedaquiline and RIPE. And so it's only reserved in cases where the benefits are thought to outweigh the risks. So in terms of how she did, so she started on RIPE. She had intermittent episodes of hypertension as an outpatient. Also had AFib with RVR, was started on metoprolol. But then given the episodes of hypertension, we repeated her echo a couple of weeks ago. So this showed a moderate to large amount of thrombus anteriorly in the pericardium. She had a small amount of free fluid, small loculated pericardial effusion around the right atrium. So again, there were no echo findings consistent with increased intrapericardial pressure. Her EF was hyperdynamic at 75%. She had mild to moderate TR. Her PSP was 39. And 5 days ago, so actually we're still awaiting cardiology recs in terms of what to do with that echo finding. But we touched base with ID infectious disease folks about the recommendation to continue with consolidation chemotherapy. And from an ID perspective, they were okay in terms of her TB regimen and receiving concurrent consolidation therapy. So 5 days ago, she was admitted for consolidation chemo. And so I thought this was an interesting case to sort of present because we do encounter the case of neutropenic fever a lot in our patients with hematologic malignancies, and rarely TB is on our differential because it's not a TB endemic area. But I thought it's good to go over it because I think in patients who you suspect, in patients from TB endemic areas, there has to be a high suspicion for TB in order to send off appropriate diagnostic workup for TB. Also, what came up was interesting was that the TBs, the tuberculin skin test and interferon gamma release assays have actually not been validated as diagnostic tools for active TB diagnosis, and it may be falsely negative or indeterminate in patients with immunosuppression. And then also, when appropriate, we get pericardial fluid even without tamponade and even when it requires an operative procedure, i.e. no percutaneous window. And then just in terms of TB guidelines, initial treatment involves 2 months of intensive therapy, and then this is followed by anywhere from 4 to 10 months of maintenance therapy. And adjunctive steroids and TB pericarditis actually decrease the rate of constrictive pericarditis, but there has not been shown to be a mortality benefit of steroids. Thank you.
Questions, comments?
I saw that the voltages on the second EKG were diffusely lower. My presumption is that's related to the effusion?
Yeah. And actually, so I think that as cardio-oncologists, we occasionally get, I think we get called a lot when somebody sees a pericardial effusion on CT scan, because they get done much more frequently than routine echoes. And I think that that you guys hit it on the head right away to think that this was TB. I think that we were concerned that that was the possibility, but the ID guys really pushed to say that they thought this was fungal rather than TB. So there was a little bit of a delay in hitting the diagnosis, mainly because the ID guys driving this thought that it was disseminated candidiasis.
It appears that there was really no way to get on this earlier, you know, in the absence of, you know, the pericardial fluid, or maybe, you know, even if a biopsy had been done, that there really would not have been any other way to diagnose this, much less earlier in the game if you did have some index of suspicion. I guess there's no blood tests, even AFB, blood cultures or anything like that for MTB, is that right?
Yeah. So, you know, it's indexed, it goes back to some basic stuff, and I think that because we're not in an endemic area, and because here at Penn we don't see a huge population of HIV infected patients, that it's not in the forefront of everybody's thinking, so that even historically, I think it would probably be the yield from asking everybody who comes from India if they've ever been exposed to anybody with TB, or anybody who actually is not native who comes from a less developed country where there's more endemic TB, that we probably should routinely begin to ask that question, because I think that if people from the beginning thought that there was a possibility of TB, things may have moved a little bit quicker. So I think that we learned from this that that, you know, when all else fails, when people have fever, you go back and you ask questions.
Do you know if on her baseline echo that was done prior to induction and you know, the chemo, Do we know if she had an effusion? I know we have the one that's a couple weeks later, but presumably if she was having fevers due to this diagnosis, when she presented, she would have had that. Did you have those pictures, or was that done somewhere else?
Yeah, so we went back. She had no fluid up to the time that it was demonstrated on the CT scan. Yeah, so it wasn't there.
Which might make sense that it was the sort of rapid drop in her white cell count with the chemotherapy that sort of finally sort of unmasked it, because it seems a very rapid accumulation of a large volume of fluid, doesn't it, between a normal baseline echo and then within a few weeks a CT that shows a very large pericardial effusion.
Yeah, so there is the thing that doesn't compute, because there was no fluid before. And we all know that you can rapidly develop large effusions. But when that happens, because the pericardium doesn't have time to accommodate, those people generally all present with pretty symptomatic tamponade. The fact that she didn't was a little bit unusual and well, unusual. I mean, it's not what you would have expected.
And just thinking aloud, I presume she had lots of chest x-rays, not least at baseline during her workup, and there wasn't in retrospect any going focus or anything in her on the chest x-rays, and obviously CT chest.
Yeah, so I went back and looked at all of the chest x-rays, and the cardiac silhouette looked, there was nothing dramatic. I mean, there was nothing at all that was suggestive that there was fluid there.
And on a CT chest, nothing in her lung apices?
No.
No. Well, of course, I'm biased. I should sort of give you my conflict, which is that the Royal Brompton Hospital is known as the Hospital of Consumption when it was founded in the 19th century, because we were in the countryside to the west of the City of London. So people picking up TB in the City of London in the 19th century got shipped out here for the fresh air. So we've got a sort of world-leading TB centre, and as a result, as cardiologists, we see more sort of complications than maybe other centres, so it's higher up on our radar.
Yeah, so it does point out that, a carpenter sees something and thinks it's a hammer or whatever, that expression. So yeah, but I think that the learning point for us is, as I said, that we have to not be so quick to start the trial stuff and forget all the other basic things that are really important. Even when people are sick, there still should be time to sit back and ask the right questions. And I don't think that we asked the right questions here.
Any other questions? I'm sorry to interrupt, Dr. Carver.
Yeah, it's okay. Yeah, and we're getting close to 10. So,
any other questions or comments from the group? Okay, thank you so much for a really interesting presentation.
Okay. Bye, guys.
Take care.